The Collaborative Family Healthcare Association, or CFHA, is our sister organization in the United States. There, collaborative care developed with the integration of behavior therapists into family practice clinics. CFHA's President Jennifer Hodgson, their President-elect Ben Miller, and Executive Director Randall Wrights were all at our conference.
But the Collaborative Family Healthcare Association, and you're going to be getting a brochure about this in a second, it was actually developed in 1993 when a group of pioneering thinkers decided that we could do better. We can do better with how we are taking care of our families, how we are taking care of our communities, how we are taking care of our providers, and they started looking at models of care that reduce the distance between not only the head and the body, but between one another. The organization is member-driven, so our membership provides us with a lot of the inspiration on what we work on. One of the things that we're doing is also through AJ, who's sitting in the front row here, is building our relationship that we're hoping eventually to maybe really do more partnership activities with all of you. We really believe that we need models that, again, integrate both the mind and the body. No longer can we say, well, you're sad, go see the psychiatrist, or your stomach hurts, go see the GI specialist. We need people who are going to really take a look at maybe, is there some connection between why somebody feels sad and why their stomach hurts? And then maybe tease out, do we need to go and move on to other levels of specialty? And again, systems that include the patient's voice, the family's voice, the community's voice. So I'm going to have Randall come up and talk a little bit about how it often begins with a story.
So the story I know best is my own story from my own community, and so I'm going to start by sharing that story with you, and then pass the baton. So I come from Mesa County, Colorado. There was a small safety net clinic serving about 2,000 people who were struggling with these same issues that Jennifer was describing of how do you treat people who have very few resources, who are having this obvious interplay between their emotional health and their mental and their physical health, who are very disconnected from their community, from their families, and who are struggling with a lot of that, or languishing, as you learned today, with a lack of strong mental health. And so back in 1999, this group, they decided they wanted to do integrated care, and we had the fortune of having a close connection with Larry Maux, who is a family, he works at a family medicine residency doing the behavioral science program. And he recognized quickly that the whole community needed to be involved in this, because this is a one small clinic offering one small service, but the vision they had was much larger than that it would involve the whole community, and that the clinic would be kind of a jumping off point to be able to get services in the community, dental, mental health, pharmacy, medical, all at one shop. And so they formed a council of the mental health center, the large nonprofit, actually the large for-profit medical center, large for-profit mental health clinic, the community resource council. A whole bunch of people got together and said, we want to help this clinic to expand what it does. And it was a great experiment, because at this time there was really a sense of these are great ideas, but they haven't been applied very much. Let's see if you can go from doing a pilot to actually doing a program. And it was a fantastic experience. Over time, one thing we've always done in our program was to do outcomes research. And because of our connection with the University of Washington, we did this pre-post study where we had back in '99, we did that kind of the screen of all the patients who were seen were given a screen for depression, anxiety, panic disorder, a bunch of different issues. And then we repeated it in 2004, and just to kind of see how had access to care improved across time. We were using the HEDIS guidelines for treatment for depression, and we just compared pre-post, and we got published in a top journal in the United States. We also started doing a lot of presentations around our community, around the state, and around the nation about what we're calling the Grand Junction model. And so a lot of what we did was try to say, we want to have a model we can identify with our community that's built around our community's needs and really is identified with our community. We have our own kind of locally grown healthcare insurance provider, and they all said, this is what we need to do in our community. This is the model we're going to embrace. First one I'd say is never go it alone. From the start, I think what brought our success is that it wasn't just that one clinic. They reached out to all the different people who could be involved and say, this is a community process, this is a community need, let's see if we can address it as a community. And part of that was actually inviting people who would traditionally be seen as competitors. And so in the United States, the mental health system is kind of stratified between the haves and the have-nots. And the community systems that take Medicaid, the government insurance are definitely the have-nots. But we've kind of got everyone to go down at the table together and say, let's have you right alongside with the for-profit system. And we kind of divided up the community and say, so here's how a person would enter the system, here's how they can go across the system to make sure that they're not going to be falling in any gaps. If you don't have agreements in place as to who's going to pay for what, when budgets get short, when times get hard, people are going to want to pull out their funds. But if you've already had a formalized agreement in place, you don't do that as likely. Also questions about who's going to be supervising which person. If you're doing a community collaborative, it can be tricky when one person's employee is working at another person's shop and they're not doing a very good job. So I think it's very important to formalize the structure, to have bylaws, to have voting procedures, things like that. And the last point I'll make is make the case at all levels and at all times. There's so many different audiences for trying to make collaborative care work in a community. There's the administrators, there's the clinicians, there's the families and the community members, and you have to always be intervening at all levels. Because I think the most impactful way to do it is through a groundswell of support from the community itself. And I think, so always going out there, making yourself known, being very warm and gracious, and expanding your resources to attract other people. Because I think because of the natural attrition that you go through, you need to make sure that you're always having someone else who's going to do the heavy lifting for you as the people who were involved early on move on.
So I have the opportunity to talk a little bit about North Carolina. When we think about state-level advocacy, we think maybe much about your provinces and how each is sort of independent in the way that it is able to function. Somewhat in the United States that's true. A lot of it is tied to insurance and what insurances they can create policies and caveats for, but North Carolina has been fairly proactive in trying to figure out how to really maximize the talent and the creativity that's happening within its state, make the most of the policy that it has, and really try to advance healthcare. Pilot projects for substance abuse protocols, for depression screenings, for telemedicine, which I hear you're also doing here in Canada. So it's just really been a nice way for them. They've been able to disseminate funds and have been able to put those funds in areas where they're maybe a little more rural, or they haven't quite figured out how to use electronic health records. We have one gentleman who's practicing, he's 82 years old, and he is holding on to his paper records like it's saving his life. And so they're trying really, really hard to work with him and help him to update his practice in a way that feels comfortable for him. The Eye Care Partnership was recently renamed when we had some new funding through the Duke Endowment. We renamed it to the North Carolina Center for Excellence in Integrated Care. So if you visit the website, you'll see sort of the names have merged. You'll see both of them on the screen. And they're primarily concerned, again, with implementing integrated care. Now, their mission has changed just a little. They're doing what's called more technical assistance work. So they will go to various sites across the state and find out from those sites, what would you like to do different? How can we be helpful? Where are your barriers in your communities? Here's what we learned in this community, and as to what these communities are able to do to care for their families and their patients with what little that they have access to. So it's enough to screen somebody for a substance abuse issue, and then to find them a place in the community that can care for it can be a huge challenge. We've been focusing a lot on emergency rooms. I don't know how it is in Canada, but our emergency rooms get overwhelmed. Yeah, okay, I see head nods, with people who are seeking care. And a lot of our providers really don't know how in our emergency rooms to handle some of the mental health needs that are coming in. And so we're trying to provide them with some of the same protocols and screenings and supports that we are for our primary care systems. So the website itself, again, is very interactive. I've listed what would be buttons or links on this particular slide. Integrated Care 102, that's a presentation, a PowerPoint that a couple of us collaborated on. It just gives you a general understanding of how to introduce integrated care in different settings and explain it both theoretically and practically. We have podcasts, again, and then different contracts that we've been able to get, like the CFHA contract, which is focused a lot with children. So it'll show you some of the pilots that we're working on. Again, this is a model for how you might be able to use this to disseminate and share. But we have national speakers come and share with North Carolina so we can learn from them as much as they learning from us. But we have this conference every spring. This was designed to keep momentum. Because if you do a one-time thing, then people tend to regress to the mean, right? They're going to go back to what they're used to. So I'm going to have Ben come up and talk a little bit about the national story.
It's probably appropriate that the fast talker go last to talk about national policy. So one of the things that we know, and I don't think I need to say this to any of you in the room, but I'll say it again, is that we know that when you integrate mental health and primary care, it's a good thing, right? Yeah, a couple head nods there. Some people maybe I need to convince. We know this. However, policy has not yet caught up to what we know. One of the things that we've recognized is that you got momentum when it comes to integrating mental health and primary care, but there hasn't been, at least in the States, and I think maybe we can even classify this as a problem in Canada too, there hasn't been a way to bring everybody together. This is a good example of that. I mean, you've got an event like this that's bringing people together, but there's what we call a cacophony that's out there. There's a lot of noise. And the noise stems from people using different words to describe the same thing. Maybe folks that are invested very heavily into seeing things stay the same instead of seeing things change. That happens almost everywhere, I think. These are quotes that we took from stakeholders that look at why there is such a noise out there around integration and policy. And you can see here, if only we had one place that we could go to and access information. If only there was evidence that was synthesized that made sense to the consumer, the community. How could I take what everybody has been doing in research and apply it? One of my favorites here, healthcare is constantly moving. Where is mental health in this? Where does mental health fit into that? One of the things that we also know is that the strategies to change policy don't just work in one setting. They work in multiple settings. And what you heard here today is you heard Randall describe the Grand Junction story. There's some pretty amazing things that have happened in Grand Junction. North Carolina, moving up a little bit. So we've got a community, we've got a state. Nationally, how can we begin to apply the lessons that are learned on the ground strategically to national policy? So it doesn't matter what setting you're working in, how can we take the lessons learned from other communities and apply them across into our community? We have a language problem. I mentioned this a minute ago. Shared care, collaborative care, integrated care, integrated primary care, behavioral health, mental health. We could probably go for another hour just doing that, right? So when we're going and we're trying to make a compelling case about policy, the language that we use is really important. Because if I, as a person who's trying to impact policy, go into someone's office, a policymaker's office, and I say, you know what? Integrated care should rule the land, and here's why. And then someone else comes in and says, you know what? Collaborative care should rule the land, and here's why. And we said the same thing, we just used different words. What is that policymaker going to think? It's a problem. It's a big problem. We got to fix that one. When it goes to making a collective case towards why integration should be impacted or, implemented into policy, we have to have more information that's standardized. Go into a practice and say, okay, what data have you collected? Well, we've got great outcomes research on our PHQ-9. So we've been collecting PHQ-9s for 12 months, and we've seen the drop in scores. Well, how much did that cost you? Well, what do you mean? Well, how much time went into that? Or how much did it cost for the provider to be there? Or what was the overhead? Or how much were the light bills? I don't know. Solutions. Same thing, I just told you is the problem. Here are the potential solutions. These guys know. I was jumping up and down on the hotel bed yesterday because this finally came out. This was published by the Agency for Healthcare Research and Quality yesterday. This is a research agenda that we have put forward for the United States as what we call prioritizing integration, prioritizing research around integration. Second thing, lack of standardized data collection. We recognize this very early on that we needed to enhance the evidentiary support for mental health and primary care in such a way that we could collectively say change policy. So we created a national network in the states that looks at primary care practices who are trying to integrate mental health. And we said, okay, guys, let's work together through a practice-based research network, and let's all answer the same question. Let's ask the same question first, and then let's answer it together. Standardize the data that we collect. We need a business case for this stuff. And our good colleague CJ Peak from Minnesota has said to us over and over again that in order to change healthcare, you have to do it in 3 worlds simultaneously. Clinical, we got that down, operational, and financial. Do all 3 of those things, and you're going to start to make a more compelling business case for policy. Policymakers care about numbers. They care about money. They care about how things are spent. There is enough money, at least I can speak for our system, in our healthcare system to do everything that we're proposing here. It's just a matter of how that money is used. You following me? Okay, and lastly, know how to make a policy case. Almost done. Policy briefs and elevator speeches. If you can't tell someone in 5 minutes or 30 seconds what it is that you're doing and why integration is a good thing, then let's talk about that. You need to have that nailed, because a policymaker may come up and say, hey, listen, what's this whole integration thing? Get it.